So we have probably quite a mixture. We have some pharmacists, some physicians, we have regular folks in the audience as well. So I'll try to go mid-range. If something just like completely doesn't make sense to you, please stop me, and then we'll talk about that. I want everybody to get some good information out of this. So you look at this list of questions, and I would say you're probably answering yes to some of these questions. And so you might look at these and think, well, some of this is just related to aging. Well, maybe my energy's less, my memory's not as good as it used to be, my sex life's not what it used to be, I'm getting wrinkles. Well, true, some of this can be related with aging, but not necessarily normal aging. So some of this can be pathological aging. And so you shouldn't confuse that. Sometimes, and you've probably been to doctors that go, well, you have certain complaints. They go, well, you're kind of getting to be that age. That I just bristle when I hear that, because it doesn't have to be that way. Because we can really change a lot of that, and we have a choice about what we're going to experience, whether it's with lifestyle, our nutrition, exercise, or even if we wanted to do hormonal therapy to fix some of this stuff. So how do we age, and what are the pathological ages? And so there's everything that happens probably boils down into a few different pathways. And so free radicals, oxidation in the body, essentially that's what happens to steel when it rusts, it oxidizes. And so kind of the cruel irony, as we age, we make more oxidants and more free radicals, and we're less capable to handle them. So how do we combat that? Silent inflammation. So inflammation is going on in our body all the time, whether we realize it or not. When it becomes noticeable is when you start having aches and pains, or maybe having a heart attack, right? So you don't feel the inflammation in your blood vessels, but we know it's there. It needs to be in the right amount, because you need some inflammation, like you cut yourself, you need inflammation so your blood will clot, right? So you can heal. But when it gets out of control, it gets out of balance, then that accelerates our rate of aging. Glycation. Glycation is simply glucose is sticking to our cells and to our proteins. And so when we don't have good glucose handling, then that accelerates our rate of aging. It actually literally can gum up the works. And our DNA. So our DNA becomes less efficient in replication, but then also all these other things affect our DNA, including our hormones and how we replicate and how our cells repair. So that's very important. One of the other things that's very important is not only the DNA in our cells, but our DNA in our mitochondria. So think back to high school biology. Mitochondria is the powerhouse of the cell. But the unique thing about mitochondrial DNA is it can't repair itself. So once that gets damaged, then your powerhouse is shut down. And so those don't repair or come back. And so then you lose mitochondria. So then, of course, hormonal decline. And so hormonal decline is a big player in age acceleration. We know that when we get to that phase of life, that so many things start to break down, and it's no accident that it's also related to change in our hormone levels. So how do we minimize that? And so these are almost roughly in order of really where our focus should be. So our nutrition, and like the talk I did earlier this year, our nutritional needs change as we age, but then also just our standard American diet is really not where it should be. And so it makes us more inflamed, it gives us too much sugar, and not giving us the nutrients that we really need. So that's really probably the first place to go. Exercise. We should all be exercising at some level of tolerance and in a graduated fashion. So, of course, are there some people that just can't exercise for whatever reason? They have adrenal disease? Sure, but most of us need to be active. And there's clear studies that show that the more active we are, the more longevity we have, the less disease that we have. Healthy lifestyle. Protecting what we're exposed to, toxins, excess sun, oxidants, excess alcohol, those kind of things, not sleeping, which probably leads into stress management. And so stress is a significant impact on our illness. I mean, probably majority of our practice, in some way, shape, or form, these people are experiencing stress-related illness, almost everyone that we see. And then balancing that, mind, body, spirit. We really are the collective result of our experiences. And so you really have to pay attention to all those things if you really want to heal. And so it's very important. And we see time and time again now the studies showing how your brain functions, how it's responding to stress, and really is affecting the rest of our bodies. And then hormone optimization. And so really almost roughly in those orders before you get down to that level. Okay. And so, we're going to answer some basic questions. What is a hormone anyway? Why does anybody care what a hormone, what does it do? And then why is everybody all spun up about it? And what should you think about before you decide to do hormone replacement therapy? So basically, hormones are part of our communication system in our body. And so the way I like to think about it, our hardwired communication are nerves. Our nervous system goes from point A to point B, that sends a signal, that's that communication. Whereas hormones are like your wireless. So they kind of float around. Sometimes it's through the bloodstream. Usually they're going to another area in the body to take a signal, to send a signal, where it's turning something on, turning something off, regulating something, producing a protein, stopping a protein from being produced. And it's all sort of maintained by the brain. So something called the hypothalamus is the part of the brain which is sort of the central server system for our hormones. And so hormones are biochemical messengers. They can turn things on and off, but also, very importantly, we found they can really affect gene expression. So a lot of times people say, well, everybody in my family's fat, so I'm going to be fat. It's like, well, that's not necessarily true. You may have a certain propensity to respond a certain way, but you can control that with your lifestyle, and even hormonal therapy sometimes changes that as well. So what do hormones actually do in the body? A lot of times people think that they just kind of turn things on and make things grow, like growth hormone. But a lot of times people are surprised that they're related with, what about cell death? Why would you want your cells to die? Because I don't want my cells to die, but what's the definition of a cancer cell? It's a cell that never dies. And so we need natural growth and cellular death in our body for renewal. It affects our immune system. It can affect it to turn it on, and sometimes to turn things off, or to make it hyperimmune. So in certain deficiency situations, the immune system kind of gets turned on too much. So have anti-inflammatory effects. Estrogen has clearly been shown, and that's part of the way that we see that estrogen is actually protective. Say, flying in the face of WHI, I know that's heresy, but there are plenty of studies that show that actually estrogen is a good thing for that. And part of the way it works can be the anti-inflammatory effect that happens. Affects our metabolism, our mood, important for preparation for new activity. New activity like flight or fight, right? So you got to have the right hormones that come to surge so you can run away from the saber-toothed tiger or drive on 285. Same sort of survival instinct. It's got to click in. Preparation for different phases of life, whether it's preparing for childbirth, puberty, menopause, whatever. Those things all have to change in tandem in a coordinated way. So when are we at our best? So hormonally speaking, well, maybe even health-wise, so in our 20s and 30s. And so that's when we're probably at our optimal for hormonal levels, and also maybe even for hormonal balance. And so then slowly we see decline, and sometimes more rapid in other times. Many times women think of menopause when suddenly all the symptoms hit, but time and time again. So of course, as our process, we start, well, think back, tell me how it was before. When did this all really start? What kind of problem? Did you ever have a problem with this sort of thing? And then people go, well, yeah, actually, I don't know, maybe 10 years ago. We'll see things start subtly changing over time, but we're not really paying attention until it gets really bad. Particularly for men. Men tend to have a more gradual. So men actually go through menopause. You think it would be called menopause for men, but it's called andropause. But usually the decline is more gradual for men, and then women usually feel it more when you reach a tipping point when change is more severe. So, but we also know that during this time is the time when there's fewer diseases, fewer serious infections, fewer bone fractures, though in general there's better health during that middle part of life. So we also know that hormonal decline is an age accelerator. So why would so what? I'm not going to have periods anymore, but we know that it accelerates aging, and that we also know that absence or hormonal deficiency is also related to mortality. And actually, there's a good study we'll talk about a little later that points that out as well. So we ascribe to something called the neuroendocrine theory of aging. And so we actually age because our hormones decline, not the other way around. So a lot of people say, well, you're getting older, your hormones are supposed to get less. Oh, it's only natural because you're not going to procreate. And nature means that once you're done having babies, then you're not any use for the survival of the species, and so you can go away. Well, we are far outliving that now. So our longevity and our lifespan's really double what it was even before then. So that's part of the reason maybe why hormonal discussion is much more prevalent, because people are living longer, they're much more active. You want to retire and you've got 30, 40 years to go and be active and be healthy and do the things that you want to do now that you've retired. So we've talked about that. So there's a lot more talk about DHRT and hormones today, but when did this really start? I mean, more than 100 years ago, they were trying to replace hormones and find some way of putting them back in the body. And then back in the 30s, they actually started creating this conjugated estrogen, right? And so they actually were getting it from the urine of pregnant women. And actually now they still use conjugated estrogen from the urine of pregnant horses. Premarin is actually pregnant mare's urine, and still is. So could they? We have probably the technology to do it synthetically, but there's still farms of horses where they take their urine from them, and they're still doing it. So there's another whole sort of ethical issue with that, actually, but it's still the same. They discovered how to make progesterone in the 30s, and then so Airst, wife Airst is still making it today in the 40s, even after they saw some association with, some cancers. So Dr. Jonathan Lee, sort of famous in the bioidentical hormone circles, even back then, was actually, promoting this even until the 80s. So it's not brand new. It's not just the newest thing. So just to kind of be clear on some of the terms that people use, because sometimes people go, well, I want to do bioidentical, because I want the natural hormones. Well, it's a little bit of a misnomer, because, actually, horse's urine, that's a natural source of, hormone, but it's not good for you. And so when we talk about bioidenticals, we're looking for exact copies of the molecule that your body makes. And so they'd actually maybe natural source derived, and usually from yam, but they make an exact copy of what's in your body. So your body knows what to do with it, it knows how to handle it, it knows how to break it down naturally with the normal set of enzymes, and the receptors know what to do with it. Okay? Versus synthetic, which are usually other kind of structures that have very different effects and long-acting effects in the body, which is where a lot of the problems come in. Okay? So they're not necessarily the same as natural hormones that people talk about, natural and bioidentical. So there are lots of large studies, even before the Women's Health Initiative in 2002, literally hundreds of thousands of people that showed the benefits, risk reduction with hormone therapy. And so how can it be that suddenly in 2002, when they did 20,000 people, women, and they came up with totally different results, and they're saying, no, stop, you're killing everybody, you got to stop doing this. How can that be in such a contradiction of, all these large studies before? But I think there may be some truth in both of them, and part of it is that they got results of what they should have gotten based on the studies and the population that they were looking at. But I think they extrapolated too far about those warnings, okay? So maybe they did get the results that we should get from that. But they've also reported it in a certain way, so there's actually been some later analysis of their own data that give us some insights into what we really should be doing and looking out for. So the Women's Health Initiative, so they looked at hormone replacement therapy, they called it HRT, and so that's looking at estrogen and synthetic progestin. And they were also doing, this is oral, okay, so we know today that we give estrogen topically because it bypasses the liver. And then they had an estrogen-only arm. So if you look at the average age was 63, so 66% were older women. And so not only that, they picked women who were did not have symptomatic menopause. Most were obese, a certain percentage of them already had known cardiovascular disease, and then 50% had other risk factors. So again, one of those considerations we look at the individual and what's going to be our risk profile when we make a decision about whether to start hormonal therapy or not. And so what they found is that their conclusion was that it increased risk for heart attack, stroke, breast cancer, blood clots. But they did notice that you had decreased risk for fractures and osteoporosis, and actually decreased risk for colon cancer. So, very, very interesting. So in spite of that, so they thought, well, okay, the risk really outweighed the benefits. You really shouldn't do this for any kind of prevention of disease. And then if you're going to do this, do it for the shortest amount of time to get you through menopause and then take it away. You ever hear the term take candy from a baby? You ever hear the term take hormones from a woman? Testosterone in particular. You think the men are antsy about you wanting to take their testosterone? It's just not true. So we look at the different arms of their trial. We look at the estrogen-only trial, and so they actually showed a decreased risk of breast cancer, decreased risk of cardiovascular disease, but a little bit increased risk of stroke and DVT. Okay? No change in mortality, though, between placebo and that. And their global risk index was 0, and the risk ratio was 1. So that means that it's the same as placebo, so there was no increase or decrease risk based on that. It's like, well, that's a positive that they never really talk about. And this is their own study. This is their results. But we know we have to pay attention. So cardiovascular disease is still a major killer of women in this country. And we also know that when women have MIs, they don't do nearly as well as men. Okay. So very important. We have to pay attention to that and consider that in our risk analysis of what we're willing to accept. So when we look at their studies, actually they only had 6 more cardiac events per 10,000. Okay, but that actually increased during the first year, but then went down by the 4th year. So this is estrogen effect on atherosclerotic disease. And then this is similar to results that were done in the past in larger studies in the HERS studies that were done. So then we looked at the secondary analysis, and let's take out the younger patients that are, less than 60. They actually had a decreased risk for coronary artery disease, down, 0.76 times of the regular population. Calcium scores were less, and so even after 6 years, they still had a decreased risk. But if they had already had cardiovascular disease, it might actually increase risk a little bit. So they don't really make that distinction. They just made a blanket statement. And so and we think this may be part of it, that it can change actually the cholesterol plaque in the artery. And so when we're giving the estrogen. So, but what the Nurses' Health Study showed, even before this, was you start therapy at menopause and then you continue it. Okay? But if you start once they get it, the same is true for Alzheimer's we'll talk about, it doesn't seem to fix that. But what they found is that estradiol actually prevents atherosclerosis in a way that statin, not the same mechanism, but almost like statins would decrease atherosclerosis. Very interesting. So we look at later analysis. They had 0 increase in mortality in that study, 35% reduction in hip fractures, 24% reduction in other fractures, 35% reduction in diabetes. Okay, they never really talked about that. They just talked about all the other bad stuff. 60% reduction in recurrent UTIs, and actually 37% reduction in colon cancer. So I think these are all pretty significant things to kind of weigh in on what happens with this. So perhaps with this, for women over 60 that may have some increased risk, then we've got to consider that. If we know someone's got severe cardiovascular disease and it's a woman in their 60s, then we've got to think about that. Some women might choose their quality of life is so bad with hot flashes, night sweats, maybe they have terrible osteoporosis. That's a personal decision. They've got to take that into account. Okay? But the recommendation is start at menopause before the plaque develops. And then avoid progestins. So here's the other kind of thing that they don't really make the distinction of, is that progestin, the synthetic, is not the same as progesterone in your body. Okay, there's a lot of confusion about that. Even the OBGYN, any recovering OBGYNs who aren't OBGYN. So they don't make that distinction. Even in their literature, they don't make that distinction. And they act very differently in the body. Okay? And they actually negate all the positive effects from the estrogen. Okay? They're reading the studies that it may be protective for the uterus in some of their studies, but they're forgetting about the rest of it, that it's really different. Okay? It actually does the opposite for everything that we're trying to accomplish. Okay? So there's actually been a couple of recent studies that show that this very same thing, that if you start estrogen at menopause, then it decreases the risk. But once you have the cardiovascular disease, then it doesn't necessarily reverse that. Memory. So they tried to say also that it maybe made memory a little worse. Okay, so this was kind of a sub-analysis in their study. But they were looking at an older group of women. And so likely they already had some cerebral vascular disease going on. So this may or may not be true. They also were giving a synthetic hormone that will increase blood clots, increases thrombin, and may change or worsen your cholesterol, may increase and does increase inflammation. So they're not taking that into account, but that's likely part of the impact on that, not just their patient selection. So we know that if you give hormones late, once Alzheimer's is developed, it's there. It's not going to reverse it. But we know in the Nurses' Health Study that if we went in ahead of time, early, that you had up to 83% reduction in lifetime risk of Alzheimer's disease. So how many of us have Alzheimer's in our family history? And so when we get to a certain age, when you're younger and you lose your car keys, you think, oh my God, I'm still hungover. When we're older and we lose our car keys, you're like, oh my God, I've got Alzheimer's. Particularly if you have a family history. So clearly something that needs to come in the mix when we're thinking about it. Again, 50% reduction in hormone replacement therapy. For greater than 10 years, a 5-fold decrease in incidence. But once it's there, you've got it. Okay. Stroke. So they showed this increased incidence in stroke, 1.3 or 8 per 10,000 person years. Okay, that was their big increase, barely statistically significant. So that's important. I mean, that's the facts, right? But so that means you got to be aware of that when we're looking at an older age group when we're initiating therapy. If they already have dementia and there's already cerebral vascular disease, you just need to watch out. So, but started early improves cognition. So the follow the long-term studies with that. So the critical period. And so that's part of what the recommendations have come out, is really a critical period. So that's why, the 40-year-olds, that's the time, Not that it's not too late later, but our best impact and effect we can have is going to be earlier on. So earlier on is neuroprotective. And so really didn't prove that the estrogen replacement therapy caused dementia or caused Alzheimer's whatsoever. And then they didn't really use the forms and doses that we use today. Okay. Cancer, 37% reduction in colon cancer, slight reduction in breast cancer, in the estrogen. Everybody, I'm not going to take estrogen, I'll get breast cancer. Time and time again, they've shown the studies that it can actually be protective. But when you put a synthetic progestin in there, increase the risk by 26%, or even more in some studies. It's interesting, though, too, the incidence of the breast cancer that they caught, as they look back at doubling times, because it takes a while for breast cancer to develop, that likely the breast cancer cells were already there, in so many of those. So that sort of confounds that a little bit. Not saying that we shouldn't be aware of that, but that sort of, confounds that report a little bit. So progestin is the culprit, the synthetic progesterone-like drug that they're trying to give. So it's mitotic, which just means it makes your cells grow. It's the thing that makes it grow. It's prothrombotic, which means it makes blood clots. Okay, everybody, I'm going to take that estrogen, I'm going to get a blood clot. It's like, well, it's the progestin that's really the thing that, and it's also the oral estrogen that may actually increase clotting, but not the topical. So if you add the progestin in, increases your risk by 29%. So progestins increase the risk of breast cancer by 8 times. And so it's interesting, people talk about FDA approved or it's bioidentical hormones compounded, FDA approved. It's like, well, the substances are the way we use it from the compounding pharmacy. They don't regulate. Okay, so it's not like they disapproved it. But we know the FDA these are approved drugs that they know cause cancer. They still allow people to prescribe. So take that for what it's worth. So remember, progestin is not progesterone. And so even as a physician reviewing the literature, you have to watch that carefully because sometimes the authors won't make that distinction. So this is just kind of a comparison. Progestins do all the opposite of what progesterone would do. So I don't want to get too technical here, but the synthetic effects on estrogen receptors. So there's 2 kinds of receptors. There's the alpha and the beta. And the way I like to look at it, the alpha is stepping on the gas and the beta is stepping on the brake. And so stepping on the gas causes growth and stepping on the brake sort of regulates that, stops that. So when you give horses urine, the equine estrogen, it selectively binds to step on the gas. And not only is it stepping on the gas, the body doesn't break it down nearly in a normal cycle like normal estrogen, so it stays on the gas. And you know, once you ever put that in your body, even when you stop taking birth control pills or whatever, it's months and months and months before it ever gets out of your body. It stays in there. Not only does it step on the gas, it keeps you from stepping on the brake, so it stops you from down-regulating that. And not only that, it actually breaks down into DNA toxic substance called 4-hydroxyaquilin, and that actually causes breaks in the DNA. If you add a synthetic progestin on top of that, it actually downregulates the beta receptor even more, so it won't let put your foot on the brake. Like, no. That's like driving in Atlanta traffic. You can only use the gas. Right. So, but we know that. So why do they still do that? I don't know. So another thing they don't really emphasize is osteoporosis is very significant. There's so much morbidity and mortality associated with that. And they didn't evaluate it in a younger woman. So if we look at overall fractures are reduced by 35% for hip fractures and 24% by other fractures. But we know that osteoporotic fractures are 3 times more common than heart attacks, 6 more times common than strokes, and 8 more times common than breast cancer. So that's pretty significant. The 2-year mortality for a hip fracture is 50%. So it's greater than the 10-year mortality from breast cancer. So that makes you kind of think about it, particularly if you have a family history or personal history of osteoporosis. Like, what's going to kill me first, right? So definitely outnumbers the risk from breast cancer, MI, and stroke combined. So, but that's not highlighted. Definitely decreased mortality from preventing hip fractures, and colon cancer actually offsets any of the mortality risk associated with breast cancer. Really remarkable. Don't forget about the reduction in diabetes and UTIs. So we know their results can be extrapolated to younger women. And that even estrogen alone is beneficial, but we would never give estrogen alone. We always combine that with progesterone for uterine protection, and as I'll talk about in a little bit, even if you don't, there are plenty of good reasons why you need progesterone. So the American College of Obstetricians say shortest time, lowest dose. I believe lowest dose is appropriate. And not to prevent the disease, what the heck? There's a whole list of things that we're going to show you that it helps with. And then the North American Menopausal Society said, well, maybe you shouldn't change the therapy if they're on it, because we actually know that sometimes things can accelerate if you stop after you stop hormonal therapy. So what if you don't have enough estrogen? So whole list of things. Heart disease, strokes, not only the misery of the menopausal symptoms, sexual dysfunction, sense of well-being, quality of life, depression, mood swings, husbands at risk. I mean, all those things are important things to consider. Personal experience. But what about the quality of life sort of things from being hormonally balanced and actually getting the benefits of therapy? Okay, so that's really important. And even in the face of some risk, sometimes that's the thing but it's a personal decision that every woman has to make. In fact, everybody that's seen me in this room knows that I never talk anybody into doing hormonal therapy. I show you the information. I tell you the benefits, the possibilities, but it's got to be a personal decision for you. So even looking at metabolically, improves your cholesterol, decreases inflammation, improves your glucose, improves your weight, your insulin sensitivity. Estrogen even works as a vasodilator, reduces blood pressure, and improves cardiac performance. So why doesn't anyone ever talk about that? Memory. So literally from head to toe, memory, eye problems, sleep disturbance, urogenital, colorectal. So literally it has benefits from head to toe. So this is a recent study. This is a Yale study this year that looked at mortality and estrogen avoidance. So what has been the impact of this Women's Health Initiative, and literally at least half of all women coming off, so probably only about a third of symptomatic menopausal women are treated in this country, and because of fear. And I remember the Women's Health Initiative study. I remember having that the JAMA article, and going to my mother-in-law and saying, you've got to stop, you got to come off of this. At that point, I didn't know any better. I'm like, look, it's saying it's killing people. You've got to stop that, and she did. Fortunately, we've learned better, and so now she's on bioidenticals today. So if you look at these numbers, premature deaths, so this is the deaths that are caused by estrogen deficiency. And when I look at those numbers, this is akin to the same numbers from the Harvard study that showed that medical errors are killing people in this country. You look at that, it's like, wow, that's a big number for this decade. And so they looked at postmenopausal women that are with hysterectomies, and actually in the 50 to 59 age group. So, and quote, estrogen therapy reduces mortality primarily by reducing cardiovascular-related deaths. Essentially, estradiol inhibits the development of atherosclerosis. It's pretty strong. But I thought, well, why hasn't anybody looked at that until now? It's 2013. Well, I found this other study, Salpeter, in 2009. He did a combination study and looked at 27 different studies, including the WHI study, and saw that a 29% reduction in mortality in menopausal women under the age of 60 who replaced their sex hormones. And so also found profound quality improvement in hormone-replenished women. So the pharmaceutical companies don't want you to know this. So what do you do? So as with anything in our practice, and we take a functional medicine approach or integrative approach, that is healthy lifestyle, exercise. I can't undo unhealthy lifestyle by just helping to hormonal balance. I mean, it's a tool just like all the other things. Exercise, diet, stress management. And we do, we look at these things. If someone's high risk already, particularly above the age of 60. And so, 60 is just sort of, it's a number. But there's a 60-year-old and then there's a 60-year-old. And I see people all the time that are my age and they look like they're 20 years older. And so that's the other point of this, is that we all age at different rates, and you can be biologically decades younger than what your chronological age, compared to other people. Okay? So estrogen replacement and progesterone replacement. So here's really some of the basic things. Start early, and we use a combination of estradiol versus something called bi-est or tri-est. And so we combine that with estradiol, which is your most common active estrogen in the body, with something called estriol, which is E3, and it actually has some protective effects. It actually helps with the beta. It helps to put some foot on the brake. I got a study I'll show you. Transdermal versus oral. We know estrogen should only be given transdermally now. So oral estrogens, even if you give estradiol, the quote bioidentical, oral estrogens increase inflammatory markers, increase blood clots and gallbladder disease, and those kind of things. But we give it transdermally, we just don't see that, because it prevents it from being metabolized through the liver. Obviously, do it daily. Bone protection requires enough. You have to have enough in your system, and not necessarily homeopathic doses. And nutritional supplementation. So nutrition is very important. You've got to put the factors in your body so that you can metabolize it. So when you give hormones, the reason you have to replace them at regular intervals is because your body's supposed to metabolize them and use them up. And they're not supposed to hang around for weeks and months in your system like the synthetics. Progesterone, with or without a uterus. And so there's some very good studies that progesterone is protective, but particularly with the uterus, you've got to do it for protective effects. Clear that estrogen without progesterone increases the risk of endometrial cancer. So that's settled. Nobody ever really has any discussion about that. So we know we've got to give it with the uterus, but without the uterus, you still need progesterone. You want to prevent estrogen dominance. Okay? So we need to balance it. You need to measure the levels and look where they are. And progesterone is a little different. You can actually give it orally or sublingually, or you can do it through the skin. Progesterone is wonderful given orally, particularly if people have sleep issues, because it actually is metabolized in something called allopregnanolone, which is a natural sedative. It actually calms the brain down, so you can actually sleep. But not addictive, and not like taking a sleeping pill, because if you have to wake up in the middle of the night and you're taking a progesterone, you will wake up. It's not like taking a sleeping pill. No progestins, they're very different. And then you got to do a daily dose. You got to stay on it. So estriol. So here's a couple of studies that look at why would you want to use estriol combined. So remember we talked about the estrogen alpha stepping on the gas and the beta stepping on the brake. So we know that alpha promotes breast cell growth and the beta inhibits it. And that estradiol activates them equally. Okay? Estrone, which incidentally is E1, is the strong estrogen that's probably more prevalent in menopause, actually tends to activate the alpha more. And then estriol actually tends to bind to the beta receptor to kind of put the brakes on for controlling growth. Okay? So when we look at progesterone, particularly when combining with estrogen, so if you use progesterone, it actually decreases the risk. If you use a synthetic with estrogen, it actually greatly increases your risk using the synthetic progestin. So progesterone, good. Progestin, bad. Okay. Provera, bad. Very bad. FDA approved, bad. Then the risk of breast cancer with progesterone. So looking at just levels. So they looked at the levels of progesterone in women in the luteal phase, or the last half of their cycle. So it's inverse relationship. So that means that the higher your progesterone, the lower your chances of getting breast cancer. That's pretty cool. So the same is true as looking at increasing levels just overall. And this is looking at pregnant women. So the more progesterone they had during pregnancy, the less chances they had of getting cancer. Which is probably why pregnancy seems to be somehow protected. Because what's really high in pregnancy? Progesterone. And estriol is actually very high in pregnancy. So that's why that probably is protected for women. So what do? So you need to pay attention to things, monitor the symptoms. Know when this is happening. A lot of times people just live with this. They live with this kind of misery. Know your hormone levels. And so when we treat, we treat to symptoms and levels. And so when we will follow up, and we follow those levels to make sure that they're not sky high, that make sure that you're metabolizing them, that we're getting them balanced. And do all the normal things that you should do for preventive health. And so anyone that's come, that we have that sheet that says, you're a part of Flowers Medical Group, and we expect you will have your preventive health things done in the recommended regimens. And lifestyle, and so taking care of yourself. And so hormones can't overdrive all the other bad things that we can do, the stressors and the things that we expose ourselves to. So you still have to pay attention and do those things. So really, we age because our hormones decline, not the other way around. And that how we do that is really up to us. And that hormonal deficiency really does contribute to premature aging and accelerates that. And that we can use that to try to restore that balance and slow aging and improve your vitality. Very good. Thanks for your attention today.